أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. In the name of Allah, the most gracious, the most merciful, peace and blessing be upon all of you. I'm Sami Ullah Malik, and it's my pleasure to welcome you to this final episode in the current series of Health Chat with the Dr. Anthony Leeds. Ladies and gentlemen, as you may know, Professor Anthony Leeds, driven by a passion for the service of humanity, initiated his scientific journey under the banner of silent killers to combat the globally renowned menace of sugar. We began documenting this scientific work, which he started sharing on YouTube and Bitter Truth website. To our amazement, the viewership skyrocketed in just a few days, reaching millions. For this, I'm extremely grateful to my entire team, which includes the Arfa Muzaffar CEO EWA's channel, Toronto, Canada, and the technical team from Canada and the Pakistan. I appreciate their efforts in delivering this program to you. We are most indebted to Professor Anthony Leeds, who worked tirelessly for these programs. My praise that Allah rewards all those individuals who collaborated with us in this humanitarian service with the best of blessing. Let me start our program now. A very warm welcome to you, Professor Dr. Anthony Leeds.
Thank you. Thank you very much.
During the series, many people have written in which questions. I'm going to ask you about some of these later, but let's begin by asking you, what are the main messages that comes from the interviews that you have conducted over the last few months?
Well, thank you very much indeed for asking me to discuss some of the components of the discussions that we've had over the last few weeks. I think probably the most important one is the fact that we now know that with sufficient weight loss, people who've just received a diagnosis of type 2 diabetes can actually move back into diabetes remission. In other words, they've slowly developed that over maybe 10 to 15 years, but we can improve it with weight loss. That's the first thing. We'll probably discuss that a little bit more later on. I think the other thing is that there are other conditions that can be benefited by weight loss. So we know that blood pressure goes down, cardiovascular risk is improved, sleep is improved. If somebody has the condition obstructive sleep apnea, which was discussed by Professor Mike Lean, then also that is improved, and also osteoarthritis. So other conditions improve as well. So I think that we're now at a position, and the main points and the main message from what has been discussed over the last few weeks is that diabetes remission is possible. We have the experimental evidence. We should now be trying to make this available in every country that needs it, which is in effect every country across the globe, in fact. Thank you.
Of all those messages, what is the most important for South Asia? One correspondent asked how we can deliver a diabetes remission in countries where and many people are relatively poor and cannot afford medicines or special diets. Are you able to advise how to solve this?
Thank you very much. I think that's a very, very important observation. The most important message, of course, is the diabetes remission one. And the way in which this was done in the trials in the United Kingdom and in other countries, in Qatar and elsewhere in the world, for example, New Zealand and Australia, was to use formula diets. And these are specially formulated foods that provide all the micronutrients, the vitamins, minerals, sufficient protein, the right type of fat, with a minimum of energy. And they are, of course, formulated, therefore they're slightly expensive to produce because they are manufactured almost to a pharmaceutical standard, and they therefore cost money. And so in producing a program that enables people to develop diabetes remission, there's a certain amount of expense involved. The other expense, of course, is the cost of staff to manage the program. So that would be perhaps medical practitioner, dietitians, nurses, other healthcare workers. And so it's a very important question to ask, how is this going to be possible where the resources for provision of healthcare are perhaps somewhat limited? Now, my colleague, Professor Michael Lean, based in the University of Glasgow in Scotland, has already addressed this by considering that perhaps we could revert to more traditional diets and the types of food that were used in the past. So for Scotland, of course, he's inevitably reverted to a diet which is based on increased use of oats, which is a slowly absorbed type of carbohydrate. And he and I are working together on a project in Nepal where, in trying to deliver diabetes remission, we were actually using a diet based on traditional foods, which includes quite a lot of legumes, which again are a type of carbohydrate which is slowly absorbed. But of course, the critical thing is the portion size. People have got to reduce the total amount of dietary energy that they consume in order to lose weight. Then I suppose the other thing that I should say is, of course, the special diet works very well on a high proportion of people. Conventional diets can work well. We know from preliminary information from Nepal that the amounts of weight lost are not quite as great as with the formula diets, but we're working on how to make that better. But you can lose weight in other ways as well. There are some medications now, but again, the economic factors would mean that those would possibly not be available in some parts of the world. And then also bariatric surgery, as has been discussed by some of my colleagues during other discussions in this series, is also a possibility. But again, there are cost implications there. So the answer is that we have been thinking about and trying to work out how to deliver this type of program where resources are limited, and there is some information available.
Of course, wanted to ask me how we can control the consumption of unhealthy foods. Can this be controlled by legislation?
Again, that's another very interesting question.
Well, we can't announce any legislation, but your voice is very strong. Maybe legislation will listen to you, actually.
Well, so far they haven't, perhaps, but we can continue. I think the key thing is that there are all kinds of different ways of trying to influence people in terms of the way they eat. You can provide information. You can provide information on food packaging, and most countries have some types of food information on the packaging. You can control this to some extent by portion size, and one of the problems we've seen in the Western world, in Europe, North America and Australia and so on, and indeed the rest of the world, is that portion sizes have actually increased. You can actually find papers that describe the size of a portion. I mean, it always tends to focus on American foods. The size of a hamburger, for example, has increased enormously in the last 25 to 30 years. The portion sizes of drinks, bearing in mind that soft drinks containing sugar, of course, provide an enormous amount of dietary energy. Those have increased. Everything is consumed in large portions and at large scale. And what we need to do then is to move back towards smaller portions. Now that requires legislation. Sorry, it requires education, first of all. But there are barriers there as well. And I have to tell you that once upon a time, I had a patient who was also a chef and who had tried to alter the portion size in one of the major London tourist attractions, and when she did so, she found that the customers were complaining that they were not getting very much for their money. So when you try to reduce the size of the portions, people complain that they're not getting very much. However, the true position is that portion sizes have to be reduced. Now, manufacturers can also address this by ensuring that the portions actually within the packaged product, if it's a packaged product, are actually reduced. When you ask the question, is legislation the answer? Legislation really is the final step in the whole sequence, because, of course, legislation, if it's applied and imposed and controlled and so on, will work to some extent. I suppose one of the most recent examples is the way in which there was a sugar tax applied to soft drink beverages in Mexico. That did have an effect on the reduction of consumption, certainly in the short term. But I think, as far as I know, there's not a lot of evidence in the longer term that it necessarily fed through in terms of benefits, in terms of perhaps childhood obesity, which is what you might be thinking of there. So legislation can, as a last resort, be applied. And indeed, I have to say that because the world is facing such rapidly rising rates for obesity and diabetes, I think legislation will be necessary at some point.
The reason why I'm asking for the legislation, actually, in these days, the countries spend more money than defense budget on this diabetes, actually. That's why I'm asking. Actually, we can spend this money to control a lot of other diabetes, cancers, and a lot of the development. Improve the development. Works in the country. That's why I'm asking the legislation, actually. Okay. Well, let I move another question. A third correspondent asked, how can we urge our government to take significant steps to better combat diabetes?
I don't know the answer to that specific question, but in general terms, in terms of trying to persuade governments to take an interest, It depends on the processes that are involved, and I think that what has been recognised is that there's first of all an educational task that has to be done. It is necessary to educate everybody at all sorts of different levels, and we particularly focus on key opinion formers, those who are going to make decisions or make recommendations about what should be done. Though those would be not necessarily scientists, or they would not necessarily be healthcare professionals or doctors. They might be people in government administration, but those would be key opinion formers. So there's education. There's also education of the whole body of healthcare practitioners who need to know the evidence for the effects of a particular intervention. So for this type of diet, a lot of work has now been done in educating people in different countries around the world about how reducing weight actually can achieve diabetes remission, and very slowly the message is getting through to large numbers of healthcare professionals. But there's another parallel process that needs to take place, which is the question of guidelines, because healthcare practitioners follow guidelines that are written to guide them with regard to decision making in the management of different diseases, and most countries have guidelines for diabetes management. And recently we've seen the publication of some new European guidelines for the dietary management of diabetes, which does include very strong recommendations for the use of weight loss to achieve diabetes remission, and for the use of this type of what we call total diet replacement, so-called soups and shakes diets, for achieving diabetes remission. Now that has then resulted in the United Kingdom, this type of diet beginning to be rolled out and applied and made available to people. But there's an economic factor because it costs money to do it, and of course therefore a decision has to be made at the right level to actually deliver that. So I think the answer is it's a slow process of education, of getting the guidelines to incorporate the experimental evidence, and it takes a very long time. In one of my conversations with colleagues earlier in the series, we discussed the length of time it takes to get new information into actual practice, sometimes up to as long as 17 years. We hope it won't be that long for this type of intervention, because as I also said earlier on in another talk, the idea of losing weight to achieve diabetes remission is not a new idea. Many physicians have been aware of this for many, many decades, but we just didn't have the high quality experimental evidence nor the method to achieve it in a high proportion of people until very recently.
You mentioned that other health conditions that are linked to overweight and obesity can be improved by losing sufficient weight. After diabetes, what is the next most important?
Well, I think what is interesting is that many people develop their type 2 diabetes in later life when they're maybe age 45, 50, 60, 65, 70, and they may well be overweight or heavy at the time. And what we usually see in most people is that they don't just have one condition, but they actually often have several. And there are various tests that you can do on markers in the blood to see what factors there are that are risk factors. And we'd very often find that somebody with diabetes would also have vascular disease, heart disease. We would also probably find that their blood pressure was raised a little. We would also probably find that their sleep was not as good as it should be. Now, when you reduce weight, all or most of those variables are improved. So, for example, blood pressure is likely to be reduced by losing weight, and to the extent that actually if they're on medications for blood pressure, you have to adjust the medications, just as you have to adjust the medications for diabetes. But also other risk factors for heart disease change, the blood lipids in the blood, the cholesterol and triglycerides and so on also change and are improved. The sensitivity of the body to insulin changes, and that has all kinds of dramatic effects on, for example, kidney function, which we've also discussed in this series, and also other tissues, other systems and organs in the body. So because many people have a combination of these things, they will benefit in several different ways by achieving weight loss. But your question was, what other specific conditions, what is perhaps the second most important one? And I would say actually it's the cardiovascular risk factors, because deaths from heart diseases are still a major cause of death across the globe. And if we could get everybody to lose 7 to 10 kilograms across the entire globe, it will make a huge difference to the prevalence of hypertension, high blood cholesterol, risk of stroke as a result of hypertension and so on, and also risk of heart attack and risk of other forms of vascular disease, including kidney disease, as we've discussed in the series. I would say the cardiovascular risk factors, including high blood pressure.
Allow me that actually I'm the good example myself actually, with your advices and good advices actually. I lost a lot of weight, and at the moment actually I'm far away from the diabetes now. Thank you very much. Well, the next question, awareness about diabetes is increasing in low and middle income countries, but resources to address this are the lacking. I'm aware that you also work in Malaysia. Do you have any initiative, perhaps based on your experience there, to address the resources problems faced by some countries?
Yes.
It's a very important question for our third world country, actually. That's why I'm asking this question.
Yes. Thank you. The answer is, I think we've got some ideas. I'm not sure that we've actually got answers. So let me just explore one or two points that I've discussed with colleagues in Malaysia. And the first one was that when we first presented the evidence that you could use the formula diet program to achieve diabetes remission, there was some concern and anxiety that people there who wanted to achieve the weight loss and therefore put their diabetes into remission would probably not like the idea of having to do what the European patients had done in Britain, and what the people in Qatar had done, for example, and what the people in Australia and New Zealand had done, which was to consume just formula diet products, the soups and shakes, for quite a long period of time. For the direct diabetes remission trial run in Glasgow and Newcastle, it was between 12 and 20 weeks, which is extraordinary. And most people think that it's not possible to do. The answer is that in actual fact, the evidence from the trial shows that it very definitely is. However, there are still problems, and you have to accept that there are differences in cultural approach to food. Now, interestingly, there are some as yet unpublished results from a study called the Preview study, which is about using this type of diet to achieve the initial weight loss in people who have pre-diabetes, so they've not yet got a high enough blood glucose to actually have diabetes, but they're drifting in that direction. And this type of diet was used to achieve a weight loss of 6 or 7 kilograms initially, and then they were maintained for a period of 3 years on conventional food diets, but low GI diets. And the evidence from that shows that people from different cultures around the world were just as able to use this formula diet as were the Europeans based in the United Kingdom. Now, colleagues who work in Auckland in New Zealand told me that the Pacific Island peoples and the Maori peoples who actually live in South Auckland found no problem at all with using the formula diet. And a colleague based in Sydney, Australia, has told me that this type of approach is now being applied in the Northern Territories for the indigenous peoples who live in the Northern Territories, and they also find the initial formula diet completely acceptable. So if we could find some way of funding it and delivering it, we would probably find it's acceptable to most people. And from my own observations of individual patients, yes, they all find the idea of doing this really quite daunting, but after a few days, maybe a week, about 90% of them actually find that it is tolerable. They can do it. They actually like it. When they start to feel better after a few weeks, they're sleeping better. If they've got osteoarthritis, their joint pain may be better. And by being at the end of 3 or 4 weeks several kilograms lighter, they actually feel better. It's very motivating to actually feel better quickly, and they then are prepared to stay on the diet. So the answer is there's no problem with people actually, most people, 9 out of 10 people, doing it once they've actually gone through those first few days. The real problem is the economic aspect, and actually the question of getting the right direction from the top of the system towards doing this. Now, fortunately, in the United Kingdom, we're at the stage where that is happening. It's happening in other countries as well, in Australia and New Zealand to some extent, in the Middle East, possibly some other European countries soon. But Mike Lean and I are working on trying to persuade lots of different people in lots of different places to consider this as an approach to achieving diabetes remission, which is very necessary because so many countries have a rising rate for diabetes.
I know that you believe education to be a key part of reducing the global problem of obesity and the the diabetes for both the general public as well as the healthcare professionals. Tell us a little about why this is so and how should we achieve this?
Well, it's a very slow process, and it's one where you really have to be, you can't just do it once and give up. You have to just keep on and on and on and on. Somebody has to keep spreading the message around and encouraging people to take an interest. And I think from observing other people and the way that they have got their messages out when they have made some important observations and wanted the way that things were done to change, I think you just have to interact with all sorts of people. You have to persuade them to change the guidelines. You have to make them incorporate information into their educational processes. You have to continuously write material for them. I think the messages are that you just have to never give up until you've achieved your objective. Now, it could take 15 years to do that. Certainly for Malaysia, I have been fortunate to be able to visit there for about 12 years over the 12-year period before the pandemic started. And during that time, I gave lectures across Malaysia on each visit. And I think we gradually recruited enough endocrinologists and other physicians and people at the Ministry of Health to get them to the point where they were supportive of the idea that we should consider offering diabetes remission in Malaysia, which is, after all, the country in Southeast Asia which has the highest rate for obesity and also the highest rate for diabetes. And you've sort of hinted at Western food practices, and of course part of the problem in Malaysia is that they have, with increasing wealth, they have actually accepted and taken on a lot of the, if you like, American-style eating practices with larger portions and the types of foods that most of us would regard as inappropriate if you want to have a healthy diet.
Dr. Anthony, thank you for all your hard work in recruiting your guests, interviewing them, and writing the accompanying text. We are all most grateful to you. At the end, I would like to make one more request. I urge you to visit this is a message for our visitors, actually. You know. I urge my visitors to visit our Bitter Truth website to watch more programs with Professor Anthony Leeds, one of the world's renowned specialists. Our website address is www.bittertruth.uk. Thanks for watching our program.
Thank you.